friends, I am Dr. Yashwant Joshi, Vice President of NAPCAIM, that is National Association of Palliative Care for Ayush and Integrative Medicine. So far you already seen that palliative care is basically a teamwork, and when I say teamwork, it requires doctors, the team requires nurses, psychologists, physiotherapists, social workers and spiritual people also. And yes, most importantly, caregivers, the people who are related with the patient and they are 24/7 available for the support, psychological, physical, financial support to the patient. So, this is about community based palliative care. When the whole community is being involved, volunteers and caregivers, and they take the complete support of the community, that becomes a community based palliative care. In short, we can say palliative care services which are being run with community participation. Medical participation is basically for the medical care, and other non-medical participation is basically by the community people. What is the conventional care? What is happening all around? I mean to say, at least in India, it is basically institution based. At the lowest level, or rather let us take it at the highest level, we have the specialist. Specialist, we can refer to PHC, primary health centers, CHC, as district hospitals. They are the specialists who provide tertiary support to the patients. Down below in the center at the village and block level, we have the PSC, primary health center, and at the lowest, that is at the bottom of the pyramid, we have the community. The complete medical support is provided by the middle section, that is the PHC and the CHC. When specialist support is required, they go to the tertiary hospitals, that is the district hospitals, and at the lowest level community, they generally do not participate except some very close relatives in patient's care. In European countries, they have got 60 to 70% people, they get palliative care services. Reasons, health sector. Why do we depend on health sector? The distribution of fund is like that because that the health sector basically depends on the government funds, and the government provides the services, doctors, nurses, everything is being paid by the government. In distribution of fund, early detection, treatment, palliative care, this is what mainly they are the important components. If early detection can take place, then thereafter diagnosis and the treatment starts, and that is how the palliative care starts early. Rural, urban and awareness is very less. So, this distribution of funds, distribution of services and medical curriculum and practices generally do not aim for all these sectors, and mainly people are not very aware about our own healthcare system. Awareness that is lacking in the public. Mostly what happens that people do not like to go to governmental institutions, governmental healthcare system, because they think they will be neglected, and they spend lots of money, go to the private hospitals, their pockets become empty. Why this is happening? First is in the society. Social groups they are not included in the health sector of India. They remain in villages. Most of them, they are illiterate, they do not know, and they remain away from the medical fraternity. These groups, they are not in the chain of services of medical provisions. Lack of awareness is there, lack of empowerment. Nobody is there to guide them, nobody is there to lead them. However, if some NGO people, they come, they can do wonders, and that is what we are basically going to talk about in community based palliative care. NGOs who are generally concerned with the palliative care system, they are very important contributor. Financial issues, dependency ratio in families 1 to 5. In a family of 5 people, there is just one earner, and if that one earner falls sick, you can understand very much. You can realize what is going to happen to those 5 people, wife and the children and maybe parents also. And non-availability of services at the village level, grassroots level. So, therefore, what is the need? Urgent need for long-term care. Long-term care, and particularly in life-limiting diseases, people are not going to die very soon. We do not know exactly. They may last for 3 years, 5 years, 10 years, and they need a long-term services like palliative care. The need of the hour, accessible medical services should be nearer to them. It should be cost effective, otherwise it just becomes like a private sector. Culturally sensitive, they must understand the cultural issues of the local population. Self-sustainable, if the community participates, community need to generate enough number of volunteers and enough fund, so that community participation remains sustainably and it can last for years to come. So, now let us define the problem. Annual death estimated worldwide is 56 million people, and in developing world, out of 56 million is the 44 million. Those who need long term care as well as palliative care is 33 million. They include cancer patients, HIV infected, and old aged people above 65 years old. This is the problem what we are facing in India. As per the latest estimates in developing world, 2/3 of all cancer patients, 3/4 of HIV infected, and more than 50% of above 65 old, they need either long term care or palliative care services. Now, let us see what is the governmental institutions, what can they offer in health sector. Key components of PHC, that is primary health center, is availability, accessibility, acceptability and affordability. This needs to be there in all the PHC center located in rural areas. Certain institution based possibilities are there. Policy by NABH accreditation, training of family members and home care nurses. This is what will come in next few lessons, that if we train the family members, when the patient is suffering from lifelong life limiting illness, definitely he is going to live longer, and therefore he needs constant 24/7 service. So, if we happen to train some of the close family members, then they perform the role of caregivers. Planned home discharge, interacting with GPs in the area, hospice care at home or hospice. If hospices are nearby, they can be admitted in the hospice, but hospice generally works out a costly affair, and therefore home care is a good alternative. working with NGOs as well as government organizations and other PC centers with the aim of increasing access, advocacy and training to improve professional awareness and availability, and publication. This is possible. These are the possibilities if NGOs or the community based participation is aware about this. Now, let us say what is community based palliative care and the possible solution. Earlier in the normal institutional approach, we saw that specialists are at the top and community is at the bottom of the pyramid. Here we have got community on the top, PHC in the center as it is earlier, and specialists they are down below. What happened? How? We could do this because of increasing role for community participation. What is a community? A group of interacting organisms, group of interacting people sharing an environment and common characteristics. Which are those common characteristics? Their intent, belief system, resources what is available to all of them, their preferences, needs and risk, etc. Therefore, we can generally say that the people living in one village, that becomes a one whole community. Common identity of the people and degree of cohesiveness, they are generally united. So, that spirit of cohesion is there and that becomes a community. From community we change over to community participation. People who can spare at least 2 hours per week to care for the sick in their locality, not only in their home. Those sick people who are located in the nearby areas, the people who can spare about 2 hours per week and then thereafter they will be enrolled to undergo a volunteers training program. On successful completion of this training, these volunteers are encouraged to form groups of 10 or 15 people and then they go to that locality, go to that community, identify the problems of such people who require palliative care intervention. These groups are to be supported by doctors and nurses in the local palliative care centers. They make regular home visits to follow up the patients seen by the palliative care team, identify and address the psychosocial and financial problems, or organize programs to create awareness in the community and to raise funds for palliative care activities, including rehabilitation projects. They function as an effective link between the community and the palliative care providers. Role of community: what are the problems faced by the patients? Physical affliction from the disease symptoms such as pain, incurable sores, breathlessness and other ailments. So, this is the physical problem because of such diseases, life limiting diseases, they just cannot move around. Anxiety about the disease and eventual death, this is normally everybody wants to live, who wants to die, and everybody wants to live longer. So, they are worrying about the disease, what is going to happen to them tomorrow, and that anxiety brings depression. The financial debt resulting from expenses, people are generally poor, they do have money, but basically they generally eat from hand to mouth. They do not have such fund available stored in the treasuries that they can spend that money when the time comes, time of distress. And to carry out such medical assistance, medical checkup, medical facilities, availability of medical facilities, they have to borrow the money from people. Inability for patient and family members to continue their professional life. Now, that is what happens in a family. If somebody falls sick, naturally certain people, they have to look after them, and therefore the earning members, they get engaged in 24/7 looking after the patient, and they cannot attend to the work, and that results into less pay. Bitter memories of frequent humiliating experiences at hospitals and everywhere. When you suffer for quite some time, naturally you have to visit hospitals, clinics, and we know already that that is how they are being treated, and they feel humiliated, and this causes a psychological problem for them. The involvement of people in the communities to solve their own problems. Now, in those problems, if those are the problems, what can we do by community participation? The people get involved. The volunteers, particularly after taking proper training, they devote themselves for the palliative care treatment of those patients in the community who need it very badly. It is of course a broad concept, simple feedback, major involvement in all the phases and area on the program. Such community participation needs assessment, planning, implementation, resource mobilization, daily management and evaluation. So, it is a well planned program conducted by a group of spirited people under the banner of some NGO, and they are totally meant for it. Every member of community cannot contribute equally. Again, they have to see that all the people in the community cannot contribute equally. Somebody who has got money can give help in the fund generation. Some people who are young and they have got some spare time, they can become volunteers. People who have got leadership qualities, they can lead such teams. Attempt to actively involve as many key groups and individuals as possible. If we want to make community participation successful in palliative care, then we should try and attract young people, as many as possible, organize them into groups and let them work under some NGOs for palliative care activities. Why a community approach? Need continuous care and attention for the rest of their lives. We cannot have doctors and nurses every hour of the day at our home, very costly affairs, and so many nurses and doctors may not be available. If available, they do not want to stay in villages. Therefore, what we need is, we have to train our own people, our own family members to pay attention to our patients. Need of regular social, psychological and spiritual support in addition to the medical and nursing care. Of course, medical care can be given by nurses coming from clinic or from hospice or from nearby palliative care centers, but the family members, they stay whole day and night with the patient, and they are the people who can provide constant social, psychological and spiritual support to the patients. They are available, community is available nearby, they can be approached anytime, accessible, they are the closest people to the home. Integrated care, all diseases, all stages, it is integrated care. This participation by the community can be applied into all diseases and at all stages, from the diagnosis to the treatment to the death and bereavement. Enough social capital available to build a safety net in the community around these patients. Social capital, when I say social capital, that means you can generate number of volunteers and they can become the people of neighborhood network, and that is how they provide a safety net around the patients. Save precious healthcare resources for acute care. Whenever acute care is required, yes, they can be shifted for for the time being to various clinics, but otherwise for a prolonged care, when the situation is stabilized, they can be brought back to home and they should be cared by the caregivers. Better outcomes, because it is a financially very viable project, and the patients, they get social, psychological and spiritual support from their nearest or closest relatives. Community volunteers. Community volunteers, they must have proper organization and administrative services, regular awareness programs in the community, training the family members to look after the patient. We call them caregivers. Training volunteers, because there is a need of additional volunteers every time, more the merrier. Therefore, training programs should be conducted for the able-bodied and who wants to join as volunteers, they should be trained. Administrative management of the unit, fundraising, as most of the community participation palliative care services are self-sufficient up to certain extent. Fund is being provided by the local people, and it is the job of the volunteers to generate fund for the administration of such projects. So, we can say the key players in are three. Community volunteers, they are the most important because they are easily available day and night. Then the primary healthcare workers in PHC, and finally in acute care, whenever it is required, we should depend on the specialist. Let us see the component of CBPC, that is community based palliative care. We have got medical component, it is required. Nursing component, generally the nurses as well as some specialists, they provide the medical component. We require trained community volunteers, because without community volunteers we cannot function as community based. And sensitized community volunteers, these volunteers should be trained and they should be sensitized about the psychological and social aspect of the patients. So, basically we can have three participating component, sensitive component and supportive component. All these components are available in community based palliative care. Benefits accrue to patients as well as families and the community as such. For the patient and families, total care, when I say total care, means it is not only attending to the disease of the patient, but they are being given psychological, spiritual, social and sometimes financial support to the patient and the families. Affordable care, because they are not being treated by hospitals or specialists, they are being treated generally at home. Easy accessibility, because the main pillar of community based program is volunteers, and this force of volunteers belongs to that community, generally staying nearby. Benefits to the community. Social capital, when I say social capital, means you are building relationship between the people of that particular society. Cohesiveness, it becomes a very bonded supportive group which can provide social as well as psychological support to each other. Improved skills, whenever you work for such projects and you help others, automatically you become little positive, you want to use your creativity, and that is how you improve your skills. Process of empowerment, everybody as a volunteer or a team leader or a nurse, even a caregiver, you are empowering them with the specific duties and work. And when you have got the skills and you have been empowered, you become more confident about your work. Not only about your work, you become self-confident you become a proud person that you are doing something for the society also, and you are improving yourself. And the community as such become self-sufficient. They do not depend upon external medical support much. The most of the support is being provided by the community participation. Community volunteers, they provide emotional support. They generally know, because they come from the same area, so they know these people, patients and the relatives. They have been trained in basic nursing. So every now and then the patient doesn't have to run to the nearest clinic. They can be given the same basic nursing care at home also. Follow-up of professional home care, linking up with the professional team and spiritual support. How do they provide social support to the affected family? They carry food sometimes for the family. If the adult person is affected by the disease, naturally the children may not be able to go to schools for the problem of fees or whatever it may be. Even these volunteers, they can provide some sort of educational support to the family. They can tutor the children at home. They can help the patients to move from their home to the hospital, linking with other support groups if required something more important, some sort of financial things. They can join up with other support groups and can raise some additional fund, helping to make potential benefits from government or NGOs available. If some nearby donors or some government schemes are there, then the schemes are being made available to such patients. Rehabilitation, and finally bereavement. After death, they provide bereavement support to the families, next of kin of the patient. Lots of projects are there. How to start community-based palliative program? There are 4 steps. First is the sensitization of volunteers. We have to train the volunteers. We have to make them into a team. Then we have to train the volunteers for little bit of nursing care and other aspects of palliative care. We have to create nursing service which can provide basic nursing care at the home, and then facility based service whenever necessity arise and some specialist facility is required. There should be some facility nearby where these patients can be shifted. This is how it goes up. The starting point is gathering volunteers, and at the end, at the top comes making use of specialists in the cities. Such community-based projects and the leaders, they must link up with the government and the community for better sustainability, coverage, better multidisciplinary approach to the program. They can link up with other organizations and institutions. Role of healthcare worker. Generally, we spoke about the role of volunteers and caregivers. Even the healthcare workers like physicians, nurses and other healthcare workers, they also play a marvelous role in palliative care. These are the evaluation indicators: input, process, output, outcome. By means of these 4 evaluators, we can find out whether the support system, community-based support system of palliative care is successful or not. So, we can summarize the components of palliative care. Competence, people should be competent, starting from health giver, health carer, then volunteers, then the nurses and the specialist doctors. Compassion, people should be compassionate, empathic. They must understand the real feelings, the psychological needs of the patient and the family, and accordingly they must behave with them. Continuity of care. Once you start giving care to a particular patient, you just cannot leave him midway. you have to keep giving the support till he lives, and that is very important. For continuity of care, we have got government sector, corporate hospitals, some NGOs. People can take help of such institutions or NGOs. Community activities, empowering community involvement, enhancing the capacity to provide appropriate care, and influencing policy at the higher level, that is at the government level. Like palliative care as a discipline is very nascent, it is still a child. We do not have palliative care projects, palliative care hospitals being run in all states of India. Kerala is in the forefront. The rest of the states are lagging behind in developing palliative care hospitals and policies. Key points for encouraging interest and enrollment. How can you encourage the people? Firstly, ask them to participate. Any help, man, money, machinery, anything from any quarter for a common agreed goal is acceptable. Do not say no whenever such help is coming to you. And nodal organizational role limited to that of a facilitator. The main center acts as a facilitator. Quality of care, how the patient is being transferred by a rudimentary boat, being carried in a stretcher with the help of volunteers. Palliative care take home message. Basic concept in PCR, basic humanitarian concepts easily learnt and applied. You must be wondering that how can we train the volunteers to provide such sort of medical care. That I already told you in the beginning that palliative care is basically a teamwork. We require medicos and nurses, but at the same time most important part of palliative care at rural level is availability of volunteers and caregivers who can be with the patient day and night till he lives. They are required for the long term care. We need to think beyond consulting room based practice. Room based practice means you carry the patient to a hospital. Here the doctors, nurses and the people are coming to the home. So, the patient remains comfortable at home. He does not have to change the place. Awareness and capacity levels needed building up. We are very rich in terms of social capital. We as a society are very helpful, and that we have been seeing it whenever some natural disaster like earthquake or flood or something comes up. You see people get united and they help each other. Even they rush from one state to another state. So, why do not you make use of this social capital and unite to fight against such life limiting diseases with the help of community based palliative care groups. Community is compassionate, large hearted, it is powerful and empowered, and evolution of models for effective link between those in need and those who hate. Thank you, friends.